Okay, now we're moving into our assessment portion of the semester, and this is a really important component to the patient's appointment. So please try and get a good understanding of what each of these components and each of these chapters are. So when we're looking at ADPI, we see that assessment is really kind of the first thing in our ADPI, first component in our ADPI. And the assessment is where we gather and analyze health information and clinical data. Now, we did go over documentation a little bit because we had to go over the medical history and any conditions that we need to be concerned about prior to our assessment to see if the patient is even healthy enough to withstand treatment before we get started. All right. Personal, dental, and medical histories. I would like to replace the personal with social, dental, and medical histories, but let's get into this just a little bit before we get too picky with it, okay? All right. Okay. Let's go over our learning objectives. We want to relate and define key terms and concepts utilized in the creation of patient histories, explain the significance and purpose of accurate and complete patient personal, medical, and dental histories, compare and contrast the different methods available for the compilation of patient histories and the advantages and disadvantages of each. Discuss how the components of patient histories relate directly to the application of patient care. Okay, so for our introduction, I just want to state that the dental hygienist is responsible for safe, evidence-based dental hygiene care. So this includes a thorough patient health history, and I want you to make sure that you review the key words relating to the preparation and use of histories, and they're in box 10-1. So when taking a medical history, it helps direct and guide the dental hygienist in preparing for, during, and following the appointment. So some key points here. The history is needed before oral examination procedures with periodontal probes and explorers. And that's because if the patient needs pre-med or you can't probe their mouth for one reason or another, they have an oral condition, you want to know that before you get started. The use of instruments that would manipulate the soft tissue around the teeth, again, they may need to be pre-medicated. When we have a patient that needs to be pre-medicated or we think might need to be pre-medicated and we send out a med consult, we don't state that they're going in for a dental cleaning. We state that they're going to have, can this patient withstand gingival manipulation? And that's where doctors then take a step back and go, okay, what do we need to do? What all does this entail? And does my patient need to be pre-medicated? When a question exists about a medical history as described by the patient, or when an unusual or abnormal condition is observed, consultation with the primary care provider or referral for examination of the patient who does not have a primary care provider is required. Even emergency treatment must be postponed or kept to a minimum until the patient's medical status is determined. So when you guys get into clinic, when I'm your instructor, I will always ask the patient, or expect you to ask the patient, when was the last time they saw their physician? Because if they haven't seen their physician for 3 years, do we really know that their health hasn't changed? So this is all part of getting a really good health history. So what is the significance? The significance of taking a complete and accurate patient history can't be overemphasized enough for the following reasons. 1, oral conditions reflect the general health of the patient. Think of the association between diabetes and periodontal disease, and leukemia, and the oral cavity, and HIV. So the oral cavity is going to give us a good idea of the health of the patient, but the health of the patient is also going to give us a good idea of what we can expect to see in the oral cavity. Okay? General health factors influence the response to treatment, such as tissue healing, and thereby influence the outcomes that may be expected from oral care. If they're immunocompromised, are they going to respond as well as if they are not, right? So this is going to affect when we write down what our expected outcomes are in our notes. We're going to have to expect, maybe not as high of a expectation when the patient's immunocompromised, or maybe we can expect it if we have all the correct components. I'm not sure which of my computers is causing that noise. I am sorry if you guys can hear that. And then the state of the patient's health is constantly changing. It is not static. Everybody repeat that. The health of the patient is not static. Okay? It's constantly changing. Therefore, it needs to be updated at every single appointment. Okay. All right, the health history preparation. The general methods in current use for obtaining a health history are interview and the questionnaire, which may be paper or electronic. We're going a little more to the electronic, the more, advanced technology gets, or a combination of the two. Now, if ever asked what is the best, you're going to say both, the combination of the two, okay? And that is because of all of those follow-up questions. The questionnaire is nice to kind of guide you through, make sure everything gets asked, and then we get those yes or no responses. And when we see the yes responses, then we're going to do more of an interview with all those follow-up questions, if you guys remember those from medical emergencies, okay? So there are several systems for obtaining the history. So pre-appointment information, you can call your patient ahead of time, and it's recommended that you call your patient ahead of time, and that's just going to give us basic information that is going to help us prior to the patient coming in. So think about what you guys already know. You already know that it takes a while to look up all those medications, right? So maybe you just want to give them a little phone call and do a screening interview, or download a questionnaire. A lot of dental offices now, you can click on their website and fill out their medical history form, and they can send it back to you. And that's really nice, because then you can start formulating all of the important information and what you're going to ask the patient. Okay, so you want to determine any potential medical problems or emergencies that may arise with the patient there. Determine if pre-medication or a consultation with the physician might be necessary. And it helps identify medically compromised or physically challenged patients where maybe we need to modify their routine care, or maybe they just even need help getting into the chair, okay? Then let's look at the self-history. Because a self-history can be prepared at home, the history form can be provided online for the patients to download and complete, and then send it via email. We talked about that a little bit with the pre-appointment information. So they can mail it or email it. If they're emailing it, and it does need to be a secure email that they're sending it to. Most people prefer not to do that. A lot of places are now getting the software where they can fill it out online, and then we can print it at the office, and it's all secured, so none of that sensitive information is given out, especially with HIPAA, right? We always want to have that in the back of our mind. This kind of form might include some items that can be checked or circled, as in a questionnaire. So the phone call is going to be more of an interview. The self-history is going to be more of the questionnaire, okay? And a lot of times the questionnaire will have a space, maybe you guys recall from going to your physician, a little space to give a little bit of information with it. All right, then the complete history. A complete patient history is made at the initial visit and is combined with is a combination of interview and questionnaire. At each successive appointment, the complete history is reviewed with the patient, and changes are considered when planning the patient care. Okay, so every appointment, if you're ever asked how often a medical history must be updated, it's going to be at every appointment. And why is that? That's because their health is never static. It's constantly changing. So when we're looking at the record forms, we have the basic history forms, and the forms are available commercially or from the American Dental Association. I believe there's a copy in your book. Let me just pull up the book here quick while I am doing this. Yes, there is a sample in the book, and it's figure 10-1. And those are Okay. Introduction to the patient. Educate the patient about why the information is requested in the history is essential before treatment can be undertaken. Convey the idea that the oral health and general health are interrelated without creating undue alarm concerning potential ill effects or harmful sequelae from required treatment. So, yes, you want to tell them that they're interrelated, but you don't want to say, oh gosh, your gingiva, can tell me if it's bleeding too much or whatever can cause, diabetes. And then all of a sudden they hear all the bleeding on probing. Well, it may not have anything to do with their diabetes. It may just be poor home care, but they may be stressed about it, okay? Or stressed that they think you're looking for diabetes. All right, so to build rapport, allow children to participate in their history preparation, but most of the information will need to be given by a parent or legal guardian. And this can be a little tricky because sometimes parents just want to drop their child off at a dental office and then go run an errand. But until they are 18 years old, the patient's legal guardian or parent needs to sign the medical history, and they need to approve the care given to that individual. Okay, so that even becomes a problem here at Herzing. We'll have parents drop it off, especially here because it takes so long to go through the routine that it can be a big issue, and sometimes parents get a little upset. So it's just about building that rapport and kind of diffusing things before anything happens. Okay, limitations of a health history or a history in general, dental or medical, social. A lot of times we're going to get an incomplete or inaccurate reading due to several different reasons. One may be a problem in the way that it's obtained or how the questions are worded. A lack of neutrality in constructing the medical history. Difficulty comprehending a self-administered test, such as people who are illiterate, or maybe English is their second language and it's given in a language that isn't their primary language. Location, you want to make sure that you aren't, that the patient isn't filling out the medical history in a very crowded reception area. If it is crowded in the reception area, go ahead and hand them the medical history form and maybe put them in an operatory, or hopefully you have another private area where patients can fill it out, not having to worry about somebody looking over their shoulder and seeing their medical history. Also, knowledge of diseases. They may not know that the overall health and dental health are interrelated. Therefore, they may think that the questions are irrelevant, and so a lot of those can be a little tricky for people to go ahead and fill it out when they don't understand why we need to know it. They may not want to talk about their health condition because it might be embarrassing. They may have infectious or communicable diseases, STDs, and they may fear that we aren't going to see them because maybe they've been refused treatment previously. All right, the questionnaire. Okay, so now let's talk about the types of questions. Generally, we're going to see system-oriented, and that's when the questions are grouped together for one reason or another. So a lot of them will do system-oriented organization, and that would be like the respiratory system. All questions related to the respiratory system would be in one area. The cardiovascular area would be in another. CNS questions would be in another area. Or they could, say, for example, specific organs. So stomach questions, lung questions, kidney questions, heart questions, liver questions. And then there can also be questions that are directed to specific disease states. Then we have disease-oriented questions, and a typical set of questions may start with, do you have or have you had any of the following diseases or problems? So when you see a medical history and you're reviewing a medical history, just because it's checked yes doesn't mean it's current. So you want to make sure, again, it is never static, right? That's why we're updating it at every single appointment. All right, so a listing under the question contains such items as diabetes, asthma, hypertension, arranged alphabetically or grouped by systems or body organs. And then follow-up questions can determine the dates of illness and the severity or outcome of their treatment. System-oriented and, symptom-oriented. In the absence of previous or current disease states, questions may lead to a suspicion of a condition, which in turn can provide an opportunity to recommend and encourage the patient to schedule a follow-up appointment. And that appointment would be with their primary care provider. So examples of system-oriented questions are you thirsty much of the time? How much sleep do you get? Do you wake in your sleep? Do you have to urinate more than 6 times a day? And then positive answers could lead to further tests for diabetes or, hypothyroidism, hyperthyroidism, whatever it may be that you suspect. And then we have culture-oriented, and questions related to the patient's cultural background can help relate to identifying ethnic and gender-related increased risk for systemic or oral disease, determine traditional cultural related health beliefs that may influence dental hygiene interventions or recommendations. Then we want to identify the herbal prep. All right, advantages of a questionnaire. It's nice and broad. It's asking a lot of questions. Again, they're not detailed, but it's covering a lot of information. It's very time-saving. It's consistent. All selected questions are included, and none are omitted because of time and other factors. The patient has time to think over the answers, so they can do it, while they're waiting for the hygienist, and they're not under pressure or under the eyes of the hygienist or the interviewer. The patient may write information that might not be expressed directly in an interview. And then legal aspects of written documentation or an electronic record with the patient's signature on it is always very helpful. Again, ideally, we would want everything to be in writing, and then hopefully, verbally given also. We don't want to rely on that implied consent, right? Okay, so disadvantages of the questionnaire is that it is very impersonal, no opportunity to develop a rapport with the patient. It's also inflexible, so no provision for additional questioning in the areas where the patient may have checked yes in the area. All right, now let's talk about the interview. It's a long-range planning for the patient's health, much more involved than the documentation or the questionnaire, I should say. And so this is going to help us build a rapport and establish that relationship between the patient and the provider. Of course, that's always going to be dependent on the cooperation of the patient. All right, so just make sure that the questionnaire is never, ever, ever done in a public place. Okay? So it's never done in the reception area. Even with a child, you want to bring the parent back and then excuse the parent if so desired. And we always want to make sure that if they don't speak English or they can't understand what we're asking, that there is an interpreter or translator present. Okay? All right, the setting. We want the consultation room or the area that we're doing this in to be very comfortable to the patient. So you want to make sure that the patient is sitting in a comfortable, upright position. You want to turn off any running water, so you don't want to be washing your hands when you're doing this. And that the dental light isn't shining on them and make them feel like they're in an interrogation room. And then you want to, if possible, go ahead and close the door to give them a little bit of privacy. Then as a healthcare provider, you want to sit on your chair. One mistake that I see students doing in the clinic occasionally, for the most part good, but occasionally I'll have to just kind of go over and offer them a chair. You don't want to be towering over your patient, okay? You want to be sitting at eye level, sit on your clinician's stool or your operator stool, and then you want to face the patient. So again, you're not going to be washing your hands or have the assistant washing their hands too, or, any background noise. So you want to be sitting down, you want to be eye level with them, and face to face. And this is important with children also, okay? Okay, so pointers for the interviewer. The interviewing involves communication between individuals. Communication implies the transmission or interchange of facts and attitudes, opinions, or thoughts through words and gestures and other means. So through tactful but direct questioning, communication can be successful and the patient will provide the necessary information. Frequently, the patient is unaware of a health problem, and we need to keep that in mind. The most effective communication for the clinician to portray is one of friendly understanding, reassurance, and acceptance. And I can't stress that enough. If they're telling us this sensitive information, you want to be very respectful of that. A genuine interest and willingness to listen when a patient wishes to describe symptoms, complaints, or current health practices not only aids in establishing the rapport needed, but also frequently provides insight into the patient's real attitudes and prejudices. So, sometimes students will say, oh, they didn't tell me that. But often they're in such a hurry that they didn't really listen, or they may have shut the patient down too early. So give them that little courtesy pause after they're done talking to make sure that they have said everything that they need to say about it. And it's difficult at times, I'm not going to lie. When you're in a hurry, you only have 45 minutes for an appointment and you got a lot to do and the next patient's already there waiting. But it's really in everybody's best interest that we do accomplish that rapport with the patient and good listening skills. Also by asking simple questions at first and more personal questions later on as the rapport develops. So you don't want the first time your patient sees you to you going right into, can you tell me if you have any STDs, or can you tell me which STDs are related to, that you may have? I see you checked it here. Can you give me a little more information? No. You want to start out with, hey, how are you? And you want to just kind of skim over. I looked over everything. I looked at your medications. And I see here, and just gradually get to those more sensitive topics. Self-confidence And sorry, I gotta clear my throat here. Okay, self-confidence and gentle efficacy on the part of the interviewer help give the patient a feeling of confidence. When you know what you're doing with a medical history, it can really gain a lot of trust with your patient. Skill is required because tact, judgment, the patient is just trusting you in so many different realms. Ingenuity and cultural sensitivity are taxed to the fullest when you're attempting to obtain an accurate and complete health history. Culturally sensitive dental hygienists will be aware of nonverbal communication issues when interviewing a patient from a different culture. So just because it appears they don't want to talk, doesn't mean that they're trying to resist the interview. That may be a sign of respect. Okay, interview form. The interviewer may use a structured form with places to fill in and check. Another method is to record on blank sheets from questions created from a guide list of essential topics. Either type of form can involve reference to the positive or negative answers on a previously completed questionnaire. So they may have completed a questionnaire and now you're doing the interview portion. Maybe this is their 3-month check, and now we're going to do primarily an interview. Familiarity with the items on the medical history permits the interviewer to be direct and informal without reading from a fixed list of topics, a method that may lack the personal touch necessary to gain the patient's confidence. When appropriate, the patient's own words should be recorded. Advantages of the interview is that it does develop a nice rapport for future appointments with the patient, and also allows for flexibility for individual needs. Details obtained can be adapted for supplementary questions. Okay, so items included in the history, please review these personal histories. Also, I'd like you to go into your case study from last semester and get nice and familiar with ours. Here at Herzing, the EagleSoft medical history that we have, and then kind of compare them and tell me what you think about that, okay? Okay. So let's, this is kind of a long slide and I just accidentally moved it. So here we go again. The AHA Guidelines, A Brief History in 1955 was the first document that was published on guidelines for the American Heart Association and prophylactic coverage, antibiotic coverage. Since then, there's been 9 revisions. The most recent was in 2007 when it was reviewed, and then updated again on their website in 2014. So the rationale for the revisions is that the previous recommendations were basically based off of professional opinions, which we know isn't the best way to create guidelines. So the 2007 and 2014 reviews attempted to be more evidence-based. Frequent exposure to random bacteremia resulting from daily activity are more likely to cause infective endocarditis than the actual treatments performed in the dental office. Antibiotic prophylaxis may prevent a very small number of cases of infective endocarditis in patients receiving dental or dental hygiene treatment procedures. There are risks associated with antibiotic-associated adverse events that may exceed the benefit, if any, of antibiotic therapy, and that would be an allergy being developed, or a lack of sensitivity to the antibiotics. So we just need to be conscious of the amount of antibiotics that we are prescribing to our patients. All right. Maintenance of optimal oral health and biofilm removal is going to be essential for these patients. Again, they're at a higher risk of just brushing and flossing and getting bacteria in there than they are in the dental office. Okay, so we want to make sure that this bacteremia isn't going to happen, and the way we do that is by emphasizing their home care. Okay, because they are daily introducing bacteria into their bloodstream if their gums are bleeding. Okay, hopefully that makes sense to you guys. All right, if not, please ask me for clarification. Hopefully that makes sense to you guys. If not, just ask me for clarification. Okay, other factors that limit conducting controlled research include low incidence of infective endocarditis, along with a variety of cardiac diseases, a variety of dental procedures. So to narrow it down to what procedures and what cardiac disease, it's just been impossible. There's just too much research that would need to be done. All right, so the following recommendations are based on the 4 principles, and these principles include: number 1, only an extremely small number of cases of infective endocarditis might be prevented with antibiotic prophylaxis for the dental procedures, even if it were 100% effective, and it is not 100% effective. Number 2, infective endocarditis prophylaxis for dental procedures is recommended for patients with underlying cardiac conditions associated with a high risk of adverse outcomes from infective endocarditis, such as a valve replacement. Number 3, for patients with these underlying cardiac conditions, prophylaxis is recommended for all dental procedures that involve manipulation of the gingival tissues. That's what the dental hygienist is doing, right? So when we send a med consult, we don't say to our patients, we don't write to the doctor and say for a dental cleaning, we say for gingival manipulation. Okay, and then things that we generally aren't doing is working in the periapical region of teeth. You shouldn't be doing that, but that's also another category that they would need coverage, and for perforation of the oral mucosa. Then number 4, our 4th principle is prophylaxis is not recommended based solely on an increased risk, lifetime risk of acquisition of infective endocarditis. All right, so the medical conditions that require antibiotic premedication before invasive dental and dental hygiene procedures. Please review box 10-2 that lists the cardiac conditions where antibiotic prophylaxis is necessary, and 10-3 lists the dental and dental hygiene procedures for which endocarditis prophylaxis is recommended, and those that it is not recommended or not needed for. A co-developed evidence-based guideline for prevention of orthostatic implant infection in patients undergoing dental procedures was released in 2012. And again, I want to say they updated it again in 2015, but these books don't, it takes a while to get them in here. So basically they're saying that premedication is not necessary for joint replacements, but basically it always says to get the doctor's approval, the surgeon's approval. Okay. Let's see here. Okay, so a consensus, the consensus in 2012 really. All right, procedures for which endocarditis prophylaxis. Procedures for which endocarditis prophylaxis is not recommended: giving anesthetic through non-infected tissue, taking dental radiographs, we don't need to pre-medicate for that, placement of removable prosthodontic or orthodontic appliances, adjustment of orthodontic appliances, placement of orthodontic appliances, the shedding of primary teeth, bleeding from trauma to the lips or oral mucosa. All right, now let's talk about our ASA classifications. Remember, ASA 1 is a patient without apparent systemic disease, a normal, healthy patient. ASA 2 is a patient with mild systemic disease. ASA 3 is a patient with severe systemic disease that limits the activity but is not incapacitating. And then 4 is a patient with an incapacitating systemic disease that is a constant threat to life. And 5 would be our moribund patient, not expected to survive 24 hours without surgery or without care. Okay, so again, we're hammering these into you because they are going to be on your boards and you have to determine the ASA classification. Okay, so we know now that it's extremely important for us to update the medical history at every single appointment. We always want to update changes in their health status, posting a plaque on the wall that states, please notify us of any changes in your health since your last visit. That will help them get thinking before they get in the back where you'll be interviewing them. Any interim illnesses that the patient may have acquired during that time. When was their last visit to their physician and what was it for? Okay, any current medications? Did the medication change? They had to go to the doctor to get a medication change. Almost always they have to, okay? Not always, but a lot of times. And then any changes in the oral soft tissues and teeth observed by the patient. Okay, date all records. A hard copy, permanent records must be written in ink. Okay, cannot be done in pencil, so don't hand your patient a pencil. Electronic patient records must be stored on a secured server on password-protected computers with only office staff having access to the computers and passwords. All electronic charting documentation are signed electronically and save in such a way that falsifications to patient records cannot be made. Provide a specific line on the health history form for the signature of the patient. We do have that in our clinic, and we have touch screen monitors so the patient can just sign it there. Maintain all information obtained for a patient history in the strictest of privacy. For patients with special health problems that require pre-medication, use some type of coded tab on the paper charts or a pop-up alert on electronic records to notify everybody that this needs to happen so that when they call to remind the patient to take it, or when they call to confirm the patient, they can remind them to take their pre-med and make sure that they have enough, okay? All right, and then analyze the usefulness of items on the patient history form periodically and plan for revision as scientific evidence reveals new information. Progress notes document regular updates of forms completed and changes in personal, dental, or oral health history since the last appointment. You can review box 10-4 for examples of progress notes. I really recommend that you do that and maybe even write them out so that you get used to that SOAP note layout before you get into clinic. This is really going to be your only option. Okay. Factors to teach the patient. Personal, medical, and dental histories need to be obtained before procedures can be completed. Assurance that records history strict professional confidence and that the servers are protected, email is protected, everything is protected to ensure their privacy. Relationship between oral health and general physical health, and the interrelationship of medical and dental care, and when pre-medication is needed and when it is not. All right, that sums up this video. Thank you.